వచ్చిన భుజాలు తట్టనేస్తమే, సభలకు వచ్చిన వితరణనిచ్చిన ఆ మాతృమట్టి కోసమే. 90లోనే బీజం వేసి చెట్టైంది ఇవ్వాలిరా, ఎన్నారైనా చిన్నలో పెట్టింది దీపాలిగా, తెలుగు సంస్కృతికే అన్నీ హోరెత్తిందిరా. జగతిన తెలుగాడి జెండా పైకెత్తిందిరా. వాషింగ్టన్ డీసీ వీధులు పోటెత్తాలిరా. లోకం తెలుగాడి ఖ్యాతిని చేకొట్టాలిరా.
ఆకాశమే అక్కై అలరించే ఈ వేదిక, తెలుగాడికి ఆహ్వానమంతమే రారెండిగా.
కళల వైభవం, యువత ప్రాభవం, ఆట మహోత్సవం, జరాలి అందరం చూడాలి సుందరం, రెండేళ్ల కోసం భరం. విచ్చేసిన తారాలోకం వినోద విన్యాసాలు, వచ్చేసిన ప్రతిభకు ఇచ్చే సన్మాన ప్రోత్సాహాలు, తెలుగు ఐక్యతకి ఆట చేసే వ్రతం. చూడ పలికింది నీకు సుస్వాగతం. వాషింగ్టన్ డీసీ, వాషింగ్టన్ డీసీ, వాషింగ్టన్ డీసీ వీధులు పోటెత్తాలిరా. లోకం తెలుగాడి ఖ్యాతిని చేకొట్టాలిరా. కొట్టాలిరా.
హలో, నమస్కారం అందరికీ. నా పేరు కిరణ్ రెడ్డి పాషం, అమెరికన్ తెలుగు అసోసియేషన్ పాస్ట్ ఎగ్జిక్యూటివ్ మెంబర్ అండ్ ఆల్సో DC కాన్ఫరెన్స్ కోఆర్డినేటర్ని. వెల్కమ్ ఎవ్రీవన్ టు అవర్ అవేర్నెస్ సెషన్ టుడే ఆన్ ది హార్ట్ అటాక్స్. అండ్ మనకందరికీ తెలుసు, ఈరోజు చాలా మందికి మనకు తెలిసిన వాళ్ళు అండ్ ఆల్సో ప్రముఖులు ఎంతో మంది ఈ కారణం చేత సడన్ గా మన మధ్యలో ఉండకపోవడం జరుగుతుంది. సో దాని మీద కొద్దిగా అవేర్నెస్ క్రియేట్ చేసి అండ్ వాట్ ఎవర్ హెల్ప్ వీ కెన్ డూ టు ది కమ్యూనిటీ, వి థాట్ ఆఫ్ దిస్ సెషన్ అండ్ గోయింగ్ టు డూ దిస్. అండ్ ఈరోజు మనతో చాలా మంది ప్రముఖ డాక్టర్లు అండ్ ఆల్సో ఆటా సభ్యులు ఉన్నారు బేసికలీ. అండ్ ఫస్ట్ ఐ వుడ్ లైక్ టు వెల్కమ్ డాక్టర్ అనిల్ రంగినాని గారు అండ్ డాక్టర్ సుజిత్ పూనం అండ్ డాక్టర్ వెంకటాల అండ్ డాక్టర్ సుమన్. అండ్ అలాగే ఆటా ప్రెసిడెంట్ భువనేష్ పూజాల అండ్ అనిల్ బుద్ధిరెడ్డి అండ్ మోడరేటర్స్ భానుస్వర్గం కూడా మనతో ఉన్నారు. టు గివ్ ఎ లిటిల్ బిట్ బ్యాక్గ్రౌండ్ అబౌట్ ఆటా, American Telugu Association is to serve and assist the Telugu community in North America. And alage, like, promoting the literary culture, health, educational, socio-economical, and also community activities in both in North America and also India. We have done many charity events past 32 years since the existence of the organization. And ATA is the first one to introduce these webinars back in 2016-17 to promote these educational sessions. So, and we have more things to tell about ATA, especially a DC conference that is coming up in June. And also the membership is also, we're growing in members because of all the events. We would like to encourage everyone to become a member of ATA. There's a lot of benefits. Without further ado, what I'll do is I'll introduce Bhuvanesh Pojala garu, ATA President, to give more message about ATA. Bhuvanesh garu.
Thank you, Kiran. Andarki namaskaram. Na peru Bhuvanesh Pojala, President of American Telugu Association. ATA enno webinarlu chestundi. ATA is the first organization introduced webinars in 2016. ఈ రోజు వెబినార్ కార్యక్రమం చాలా ఇంపార్టెంట్ది. ఒకప్పుడు హార్ట్ అటాక్స్ అంటే లేట్ 60s 70s 80s అలాంటి వాళ్ళకి వచ్చేటివి. కానీ ఈ రోజుల్లో హార్ట్ అటాక్స్ కామన్ అయిపోయాయి. ముఖ్యంగా యంగ్ జనరేషన్లో, మిడిల్ ఏజ్ గ్రూప్స్లో కూడా వస్తున్నవి. సో ఎందుకు, వీటి కారణాలు ఏంటి, ఎందుకు ఇండియన్స్కి ఎక్కువ వస్తున్నాయి, వీటి గురించి తెలుసుకోవడానికి సో వీ హ్యావ్ అవర్ ఎక్స్పర్ట్ కార్డియాలజిస్ట్ ప్యానల్ టుడే. థ్యాంక్ యూ సో మచ్ ఫర్ జాయినింగ్ అస్. ఈ సెషన్ని మీరందరూ కూడా యూజ్ చేసుకొని ముందుకు వెళ్తారని ఆశిస్తున్నాను. ఈ కార్యక్రమానికి మా యొక్క మోడరేటర్, మా యొక్క మీడియా కమిటీ చైర్పర్సన్ భానుసుబ్రహ్మణ్యం గారిని టేక్ ఇట్ ఫార్వర్డ్ చేయాల్సి కోరుతున్నాను. థ్యాంక్ యూ. థ్యాంక్ యూ భాను, ప్లీజ్ టేక్ ఇట్ ఫార్వర్డ్.
Yeah, thank you so much, Bhunesh Garu, for doing this. And thank you, Kiran Pashim Garu, for the brief introduction. And when we discuss this, that we have these issues pretty common in the community, Dr. Sujit Punnam and Dr. Anil Ranginani and Dr. Mohan Alla, they came forward to help us out. And with the current situations which are happening, as we see pretty commonly these days, you always know somebody who actually is your friend who's no longer, probably they must be in their 40s or 50s. And then when we did some research on this, it's actually looks like it's much more prevalent in the Southeast Asians, especially Indians, about the 40 age group. So Dr. Sujit and Dr. Mohan Alla and Dr. Anil Ranginani, and we have a survivor. He's a doctor himself. So they are going to speak about how we are going to what all the measures we need to take in order to have these concerns addressed. I know that Manaki, even though we have health insurance, most of us try to, not even get the physicals done. So they'll probably give you some tips and what needs to be done from their perspective. With that being said, let me briefly introduce the panelists which we have for today. So let me start off with Dr. Anil Ranginani. He is an interventional cardiologist in Indianapolis, and he graduated from Kakatiya Medical College. Thank you, sir. Thank you for coming forward to doing this. And we have Dr. Sujit Punnam. He is one of the health committee chairs and for ATA. And Dr. Sujit Punnam is based out of Stockton, California, and he's an interventional cardiologist and a board member of San Joaquin Medical Society and American Association of Physicians of Indian Origin. Apilogoda, he is very active, and he graduated from Kakatiya Medical College. Thank you so much, sir. And then we have Dr. Venkat Alla. He's a cardiologist and associate professor in Creighton University, Nebraska. With that being said, Dr. Venkat will go first, and he'll have some sort of presentations which he'll present. The request to the members are to the people who are watching this. We have a Q&A session. Maku Q&A session kuda undandi, and all of these doctors can even speak Telugu. If you have a Q&A session, please post your questions, and we should be able to answer those. And all these questions would be answered only at the tail end of the process. With that being said, Dr. Venkat Alla, please take it forward, sir. Thank you.
Good morning. I hope you're able to hear me. All right. So thanks for providing me the opportunity to talk to this group. Na peru again Venkata Mahesh Alla. I work in Creighton. My focus is preventive cardiology. So the title of my talk is Cardiovascular Disease in South Asians, a convergence of two cataclysms. So over the next 20 minutes or so, my hope is to convince the audience of the burden of cardiovascular disease that South Asians living in the West face. I will also discuss the factors that contribute to this high disease burden in our, whether it is genetics or environment or habits. And over the last few minutes, I will touch upon what we can do as physicians and people from this area or as patients. I will leave the bulk of this to the subsequent speakers though. So number of speakers have already said, you know, we all need to know why we are here. And I think the press, if you follow the press in Andhra or Telangana, you see this celebrities dying pretty young, you know. On the left of or the right of the screen is the young minister Gautam Reddy, who unfortunately passed away recently. And on the right is Mr. Rajkumar's son, who is himself a celebrity in Karnataka. So this is not just uncommon. This is the tip of the iceberg. Even in sporting personalities like Saurav Ganguly and Avi, the other guy on the right, is a 30-year-old captain of under-19 India cricket team who died of a heart attack. So, you know, he is a Saurashtra cricket champ. And you all probably are aware of Saurav Ganguly's hospitalization for 2 heart attacks within the last year. While the press does give a lot of coverage to this high-profile people, I think that is just the tip of the iceberg. As South Asians, if you look at the small area of the world we inhabit, we contribute to 25% of the population. So we are a lot of people. So there is more than one reason for us as a community, as physicians, to be taking care of health here, because whatever we do matters to 25% of the world population. And as an American or living in America, we also are facing it, whether it's physicians or people. There is a significant growth of the Asian population in America, and South Asians specifically are 4 times more prone for heart disease. So for understanding what a South Asian is, I know this is an audience that is focused on the Indian community, but the research is essentially on South Asians. So anybody from any of these 7 countries, whether it's Pakistan, Nepal, Bhutan, Bangladesh, India, Sri Lanka, and Maldives, constitutes a South Asian for the duration of this talk and for most epidemiological studies. There are other definitions which are not as well accepted, some of which include Afghanistan or Iran, but essentially this is the most common way of defining a South Asian. And if all of you are aware that South Asian migration started very late in the 19th century or even in the early 18th centuries due to colonialism and all the migrant labor, migrant railway workers. Though in North America, I think the migration is much later, starting with the Punjabi farmer migration early in the 20th century and mostly professional migration after 1970s. So anyone living in South Asian country or anyone who lives outside South Asia but has migrated from South Asia, and anyone that shares genetic ancestry with South Asians is considered a South Asian for purpose of epidemiology and assessing disease. So what exactly is the scope of the problem we are dealing with? There are about 500 million people with cardiovascular disease. For those of you who are not in the medical field, this essentially means heart attack, strokes, or congestive heart failure. 500 million people in the world. And out of all deaths in the world, 1 in 3, so out of 100 people dying, 33 people die from cardiovascular cause. So in 2019 alone, there were 20 million deaths attributed to cardiovascular disease. That's a lot of people dying from heart disease. As I've said, South Asians contribute to 25% of the world population, but we contribute to 60% of the disease. So 25% of the population holds 60% of the burden of cardiovascular disease. So among all the people we talked about, 525 million people, more than 250 million people are those South Asians. When you look at the deaths, out of the 20 million deaths, while we constitute 25% of the world population, we constitute 9 million of the deaths out of the 19 million. So that's almost 50%. So we have a lot of burden of this disease. We carry a not a nice burden of this disease. As I've again said, South Asians are increasing in the US, and Indian population particularly constitute 20% of the Asian population. That's about 1/5 of the Asian population. Right now, the estimates are there are about 5 to 6 million South Asians in the US, and this is by 2060 going to be 15 million. So that's a lot of people of Indian origin in America, and I think we need to cater to this population's health. So going into a few studies, I will not burden you with a lot of the research and data, but I want you to focus on where the stars are, and the blue bar indicates the burden of disease. So the higher the blue bar, the higher the burden of disease. So the first bar is South Asians. And if you look at any other bar, whether that is East Asian, Asians in general, Hispanics, whites, every blue bar is lower than ours. So what it essentially means is that we are having a very high risk of heart disease compared to other ethnic groups. On the right side of the screen, you see that South Asian, being South Asian itself, increases your risk of heart disease threefold. That is a big risk factors. We are traditionally taught that smoking, diabetes, hypertension, cholesterol are risk factors for heart disease. We have never taught being born in South Asia is a risk factor for heart disease. If you look at all these risk factors, the only thing that beats South Asians is diabetes. So if you grade the risk of heart disease based on how much they're contributing, at least in most of us, diabetes is number one. Being South Asian is number two. Being male is number three. And having a high lipids and cholesterol and blood pressures are the numbers after that. So the very fact that we are South Asians, we are like hamstrung with a high disease burden. So the first paper I showed you is from California, but this is from London, British. Same results. The blue line is disease of heart disease risk in Europeans, and the red line is South Asians. So we are almost 50% higher. Very similar result again in Canada. So wherever you look, and I can keep showing studies from Indians in Nigeria, in South Africa, in Spain, it doesn't matter where we are. Essentially, we are at a high risk than the other groups of population. And this is an important study that Salim Yusuf from Canada did, and across 52 countries, where they assessed risk of heart disease, first MI, and what are the differences in the various ethnic groups or countries. Not only did we have a high risk of heart disease, but South Asians on average developed heart disease 10 years earlier than whites. So not only do we have a high risk, but we develop it very young. So if an American or a white person has a heart attack at 60, on average, we are having it at 50. So that's a lot more loss of life. Second, not only do we have disease, not only do we have early disease, but we die from the disease more often. So the green bars here is the death rate from coronary artery disease or heart attacks in South Asians, whereas the teal blue is the Canadians that are not South Asian. So South Asians have a mortality rate of 42% when they have coronary artery disease, whereas 29 only die if they're non-South Asian. So whether you look at male on the left of the panel or the females, the death rate from coronary artery disease is much higher. So essentially what I'm trying to convince you of here is that we are 2 to 4 times at greater risk of cardiovascular disease than non-Hispanic whites. We have a 40% chance of dying from the heart attack, that is more than the non-South Asians. We develop this disease 10 years earlier than the white counterparts. And the more stark statistic is that 25% of the heart attacks in South Asians occur in people younger than 40. So out of 4 people that are having heart attacks, 1 of them is younger than 40. 2 of them are younger than 50. This is just very young. And we have the highest hospitalization rate for coronary artery disease. So I think any measure of disease, we are not really doing well. how do we deal with this disease? Once we have disease, we present to the hospital later, whether that's cultural or we are not aware, we don't have health education, we don't recognize the symptoms. So this is a study that came out of Interheart and Canadian societies. We presented later to the hospital. We had a higher risk of bigger MI, which we call anterior MI. We had a higher prevalence of multiple blockages, not just one blockage. And not surprisingly, the care was similar. The hospitals recognized and treated patients, whether they were South Asians or not, very equally, unlike there's a lot of data right now on African Americans not being recognized or women not being recognized, but that's not true in South Asians. I think the doctors are recognizing it and treating it, but despite this, we don't do well. And I've told you that we are also younger. Now, one of the things that we as cardiologists use is risk evaluation. We have scores that generate risk of heart disease. The problem is, due to lack of research, most of the scores are not geared for South Asians. So we are using scores that are derived from whites and transposing them to South Asians. And that's resulting in inaccurate estimation. So when you see a doctor, even with the best intention, when the doctors calculate your risk, they're underestimating risk because their calculators are imperfect. So you use an imperfect tool, the answer is imperfect. Now, there has been some progress with newer tools, both on the European side, British side, and American side, recognizing that South Asian is a risk factor. So they now adapted these tools to multiply it by a 1.4 so that we can come closer to the reality. So again, to recap the last few slides, we don't recognize symptoms early enough. So we therefore go late to the hospital. And the patients themselves and the physicians, even with the best intention, underestimate the risk of heart disease in these South Asian groups. Now, there's the silver lining is there's a lot of research going on. Most of it is in California for sure. So I know that a lot of you are based out of there. But across the world, there is now an increasing recognition of this, and there's a lot of research going on. Hopefully, Pramila Jayapal's act gets into legislative thing, and there will be more funding for South Asian-based heart health research, though this is still in the House. I don't know when it will make progress. It's been stuck there for a couple of years now. So why are we so destined to have this heart disease? I think it's a combination of our risk factors, our genetics, the sociocultural behavioral patterns in South Asians, and the environment. So if you look at the risk factors, most of the South Asians compared to non-South Asians have a higher risk of diabetes and pre-diabetes. Insulin resistance, I would like you to understand that as pre-diabetes. Hypertension is marginally higher, but we also have higher rates of what we call diabetic dyslipidemia, or abnormal fats related to diabetes, which is triglycerides. And we have a lot of central adiposity, we call it visceral fat. So that's, I call the lean fat. So you are looking lean, but you are fat. So a lot of research has now focused on this thin fat phenotype of the South Asians. So where their BMIs are normal, but they have a high fat content in their visceral organs, which is called the visceral adiposity. They've also done a lot of research on the hyperinsulinemia or insulin resistance and the abnormal lipids. So this is a classic example of a study that was published. It's just one patient study, but it was published in Britain. So on the left is a British Caucasian. On the right is an Indian, both of them living in London for a long time. Both of them have exactly the same BMI, so the height to weight thing. But if you look at their body fat calculated on this scanner, the body fat is almost 2.5 times higher in this thin Indian. So when physicians look at it, or when we look at ourselves, we think we are healthy, but that's not true. The body fat or the visceral fat is so much higher in South Asians. We still don't understand all the mechanisms, and one of them is diabetes and pre-diabetes, but that is an important factor to register. So I want to summarize this and say that diabetes, pre-diabetes, and the central or visceral adiposities or the thin fat phenotype is an important, or one of the important reasons for the high disease burden in South Asians. Now, there is a lot of emerging knowledge on some other markers. I don't want to belabor this with our audience who are not mostly medical field. But I also want to kind of say that 80% of 85% of our risk still comes from the known risk factors, which is diabetes, pre-diabetes, instead of all these novel things. So we still don't want to neglect what we know and still focus our energies on what we know rather than the novelties. Now, there are certain factors beyond risk factors in our heart disease predisposition. A lot of it is genetics, how we react to bad food compared to a white American, the economic stress of migration with the first generation immigrants, the issue of lifestyle changes that is brought about by migration. We all come to the US, and I mean, maybe it's not true now, but 20, 30 years ago, we never had burgers in India. We never had fast food in India. Now I think India is, as when you go from a village to a town in India, it's exactly the same thing. So the dramatic lifestyle changes that are coming with the Western lifestyle and the background socio-cultural habits that we have from many years, they all combine to increase our risk. Some of these are religious, some of these are our perceptions of health, some of it are our family dynamics, some of it social norms, some of it is just our belief maybe in less established therapies like alternative therapies or less tested therapies. I don't mean to say they are wrong. And our attitudes to healthcare providers in general. We can talk about not eating meat, leading to high carb diet. We can talk about our health perceptions where we say we don't go to the doctor unless we get sick. We can talk about family and social norms, like women may not like to go to a gym and exercise; they want to be more private. And alternative therapies, now some of them are good, yoga, but some of them may not be well tested, and we still have a lot more faith. We don't ask the right questions. And then our attitudes to healthcare provider for right reasons or wrong reasons, avoidance of pills seems to be a big thing in our culture rather than taking a pill when it's necessary. And I don't think I need to preach to our group about what diet we eat. It's very rich in saturated fats, very rich in deep fried foods, carb-rich foods, rice and rotis, and salt-heavy pickles. And we eat way less fruits and veggies than what we should be eating. So I think this combination of adoption of Western lifestyle and genetic and biological predisposition is what is resulting in these two cyclones coming together and creating a mega cyclone. So what can we do? Over the next couple of minutes, I'll just close out by saying what we can do. We can't change our genes, definitely not. But we can be physically more active, adopt exercise early, and make sure our kids adopt it early. We can go to a diet that's more rich in fruits and veggies and less in fats, all the bad things we showed on the earlier slide. We can educate each other. I think as a community, it's our responsibility as physicians and as people to educate each other about the risks we are facing, because it's a common battle. I have family members who died, and I have friends who died. And then I think our attitudes to physician healthcare should change. Prevention should be a big thing, because we believe in taking treatment only when it's needed and not taking treatment to avoid disease. And then as a community, I think I appreciate what ATA is doing to get the community together and on board, because we can only fight this as a group and not individuals. So I think we should all increase our health awareness and work to increase our families and friends' health awareness. We should make sure that everybody tries to adopt a healthy lifestyle early on, starting in their teenage. I see all my nephews in India at 16 doing things that I always preach not to do here. Early and aggressive risk factor screening. Don't be hesitant to go to the doctor at 20, get screened for heart disease, cholesterol, diabetes. Be proactive. Seek preventive care. And be a partner with your physicians on risk assessment, because I don't think the physicians are also having accurate tools. So I think you should have conversations. There are a lot of new technologies like calcium scores. So I think it is an important conversations early on, not after you have disease. I think we should all say goodbye to some of the myths. There are always a lot of myths in our culture that may not be appropriate. So I think we should take a scientific approach and do what is evidence-based. And most importantly, be aware of symptoms and seek early medical attention. I think every kid should know what the symptoms of heart disease are and what needs to be done. And we need to build systems to take care of these. We should also give up this mentality of karma that if you're destined to have it, we will have it. And I think we should get away from that. I think this is preventable. We should not blame our religion or karma or fatalism for this. We should change our perception of being healthy. What is healthy? You know, when I was in Punjab, healthy means they never said somebody is fat. They said somebody is healthy. So I think our perceptions of thin fat should be the norm. So we should understand that being thin is not being healthy. You know, we should give up our bias against any pills, particularly preventive care pills. We should have more trust in physicians. And at the same time, question some of the alternative therapies which are less proven. Adopt some of the alternative therapies like yoga, which are more proven. We should stop telling ourselves at 45, it's okay to have a heart attack because we believe it's old. My dad had a heart attack at 44, and he always said, I'm old, I'm ready to die. And he died at 52 with a heart attack, which I think is a crime. I treat here patients of 80 and they tell me that they are young. I think we should give away our perception of being old and treat ourselves better. So in conclusion, our genes may not be a blessing for us, but we should not accept this destiny of doom. Every healthy decision we make today will reshape our destiny as people and as a community. So I will stop here and stop my screen share and allow the other speakers to take over and carry on what. Thank you all for your attention.
Yeah, Sujit Garu, it's over to you, Andy.
Hi, everyone. I congratulate everyone for attending this webinar on a Saturday. I know it's a very important time. It's time for the family and all. But I think it's an important topic for all of us to get some understanding. And after this eloquent talk by Dr. Allah, I will try to fill in some gaps about what exactly is heart disease, what is a heart attack, things like that. Okay, so just a brief overlying anatomy of the heart. If you look at it, there is a right-sided chambers and the left-sided chambers. All the ones that are red is the pure blood. All the ones that is greenish blue is impure blood. And we have 4 valves within the heart, and the red tube that you see is the aorta. So a pulmonic valve is in between the right ventricle and the lungs. The tricuspid valve is in between right upper chamber and right bottom chamber. Mitral valve is in between left upper chamber and left bottom chamber. And the aortic valve is the main door between the heart and the body. As Dr. Allah alluded to earlier, cardiovascular disease is the #1 killer, whether it be in the United States or in India. About a decade ago or so in India, cardiovascular disease was not #1 killer. It's predominantly the infections that were taking a huge toll. But with the westernization, with the diet changes, with the lifestyle changes, that has overcome every other reason, and the cardiovascular disease has become #1 disease, even in India right now. So there are different types of cardiovascular disease. If you look at it, coronary artery disease means the arteries that take blood to the heart muscle have blockages, and whatever the process that comes from the blockages, in either in terms of abruptly or gradually, we attribute that to coronary artery disease. And the second one is a valvular heart disease. The 4 valves that I talked about, they could have narrowing, they could have leaking, and some of them are congenital, some of them are wear and tear process as we get older. And the third thing is heart failure. Heart failure means whatever the heart is getting, the blood that it's getting, and the amount of blood it should pump out into the heart, into the body, is impaired. And some of these heart failures are related to dilated, meaning enlarged heart, and sometimes it's not enlarged and the cavities are the same size, but just the stiffness of the heart muscle contributes to the problem. Just a second, please. Okay. Can you all see my screen?
No, the screen is gone. We just see you. You're back.
Okay, thank you. Sorry for that glitch. And what is a heart attack? We hear a lot about heart attack, and there is another component of the heart attack also called angina. Like every organ in the body, heart also needs blood supply to survive. This blood supply is provided by coronary arteries sitting on top of the heart. As you can see in this visual, the artery is blown out here and you can see the blood cells going in. Due to some conditions called risk factors, what we call, these arteries develop fatty deposits inside the lumen called as atherosclerotic plaques. When the plaque buildup happens gradually and reaches the point of about, normally we take a cutoff point of about 70% most of the times in clinical practice, the mismatch that happens between the oxygen demand in the heart muscle and the supply contributes to the heart manifesting symptoms to warn us, and usually it takes the form of a chest pain, and this is called angina. Once in a while, the plaque ruptures abruptly, and all of a sudden, the blood clots in that area, shutting off the circulation, leading to death. And that is what we call as heart attack. What are the preconditions? Until about 1960s, we did not know much about this. But in 1948, National Heart, Lung, and Blood Institute, which is a subsidiary of National Institute of Health, commissioned what is called the famous study called Framingham Heart Study. Framingham is a town in Massachusetts. It's at that time represented the quintessential demographic of America in terms of percentage of Caucasians, African Americans, Hispanics. And this is a longitudinal population-based epidemiological study. So they enrolled a huge number of patients in this study. And later on in 71, the offsprings of that cohort, of whatever those thousands of people were enrolled, the offsprings were also enrolled again. And the data from their examinations and the recording of the disease provided us with a landmine of data to analyze and come up with what are the risk factors that we call today and what we know today. Out of which main things are being of higher age is a higher risk, being of male sex, if somebody is smoking, hypertension, diabetes, hereditary factors like risk, family history of premature heart disease, high cholesterol, and a type A personality, which creates stress in the person. Being overweight, etc., are the risk factors contributing. So that's how we know the plaque formation and the heart attacks happen because of these risk factors contributing to internal dynamics. As you see, some of these are modifiable, but some of them are non-modifiable. You cannot modify age. You cannot modify being of male sex or female sex, of course, other than some minority. Diabetes, hypertension, smoking, these are all modifiable risk factors. So just the pictorial, and lately, some studies are showing that pollution can contribute to that. Sleep deprivation, which is, I think, is very important, because as the stress increases, your sleep deprivation increases and contributes to the heart disease. And rest of everything we've already talked about: diabetes, insulin resistance, obesity, poor diet, and exercise. Just a little interlude in this talk. Learn hands-only CPR because it saves lives. And I know ATA is arranging a Learn CPR session tomorrow, so please do attend that. So what can we do to look for this condition ahead? How do we prevent this condition? We need to look for modifiable conditions. Blood tests, if you do a preventive checkup, like a routine annual physical and blood test, you can see if they have diabetes or pre-diabetes, if they have high cholesterol. When you do a physical evaluation, you can check for blood pressure and see if they're hypertensive. And when you talk to them, you know what is the family history. Anybody of their first degree, brothers, sisters, mother, father has any heart attack? And if so, at what age? Because if they had a heart attack at 85 years of age, that doesn't mean a whole lot. But if they had it in the 40s, that will tell you that person is predisposed to higher chances of a heart disease. That means you need to attack their risk factors much more aggressively. And based on these risks and based on the tests that we do and the physical examination we do, we can come up with a 10-year risk of atherosclerotic cardiovascular disease risk score. Initially, the Framingham Heart Study that I talked about had a Framingham Heart risk score. Lately, we call it as atherosclerotic cardiovascular disease risk score. And then we can come up with whether they have mild risk, moderate risk, or high risk. For mild risk, we usually recommend lifestyle changes. If somebody has a risk of less than 7.5% in the next 10 years, that is a 0.75% in 1 year, that is mild risk. So we usually recommend lifestyle changes in that situation. For moderate risk, somebody with a risk between 7.5% to 20%, we could consider doing a CT scan to look for coronary calcium score to get some information of the plaque. This works on the basis of a premise that calcium gets deposited on the plaque as the time goes by, and CT scan can pick up this calcium since calcium is radio-opaque. So a typical study for coronary artery calcium score, usually the Medicare doesn't cover this test as of right now, but it's less than $100 in any center usually throughout the country. So it's very easy to do, very quick test. If you have a normal looking heart and vessels, look at in the left panel here, no calcium, and your score is 0, that means your plaque burden is minimal, and the risk of cardiovascular disease or having any events is very low. Whereas in the middle picture here, you see some moderate calcification, and you can come up with a score for that, like a calcium score for that. And if it is less than 100, we usually call it mild burden. 100 to 300 is moderate burden, and more than 300 is severe burden. And these are the people who have higher risk of having cardiovascular events going forward. So that means you need to take their risk factors seriously and treat them aggressively. Other tests that we can do, for high-risk people, we recommend cardiac stress testing to challenge and see if the plaque that is there in the arteries could cause problems when they are exercising. Sometimes they come with chest pain, we do a stress test and it is abnormal, we take them to angiogram, look for a blockage, and if it is severe, which is more than 70%, and usually we put stents in, or if there are too many blockages, we send them for an open heart surgery and bypass those blockages. We generally do an electrocardiogram, which also gives some information on the rhythm disturbance, or we also do an ultrasound of the heart called an echocardiogram to look at the squeeze function of the heart, what's the thickness, how is the valve doing, to look at other kind of heart diseases. If at any time someone has symptoms of chest pain with exertion or suspicious for angina, we can skip most of these and directly go for angiograms. So risk score doesn't usually play a lot of role at that point. Now, when to call 911, which is the EMS system in the United States. If the plaque builds gradually, it causes angina, which is a typical reproducible format of symptoms. They can be assessed in the physician office setting. You don't need to panic about that. But if the symptoms happen abruptly and you don't have time to the doctor's office, and you have to check that immediately, and at that point you call 911. And what are the symptoms of heart attack? Chest pain, typically, more like a chest pressure. A lot of people describe it as an elephant sitting on the chest, like a heaviness, sometimes shortness of breath, usually associated with sweating and sometimes with palpitations. Some people comment that radiates down to the neck and the arms. Sometimes more commonly in women and diabetics, the symptoms can be very atypical. They don't have chest pain, they have nausea, they have fatigue, they have belching sometimes. You think that it's a gastrointestinal problem. So having a high degree of suspicion in an appropriate setting helps a whole lot in identifying the problem. And some people confuse heart attack with a cardiac arrest. There are two different entities. Cardiac arrest is an electrical abnormality of the heart, wherein the person collapses suddenly because the heart goes into a standstill. Heart attack can also cause cardiac arrest, but usually not the other way around. And needless to say, you call 911 if a person collapses without a good reason. And there are some differences in terms of men and women. In men, sometimes it predominantly manifests as chest pressure associated with some nausea or some jaw pain or neck pain, shortness of breath. But in women, it could be shortness of fainting, like, just passing out, indigestion, extreme fatigue. So the heart symptoms are a little more deceptive in women. But bear in mind, the heart disease is still the #1 cause in women in terms of mortality and morbidity. It's not the breast cancer or ovarian cancer or cervical cancer, whatever. It's still the heart disease. So there are different things that there are some differences. We can go over that from men to women in the following slides. As Dr. Allah alluded to earlier, there are some emerging risk factors and the traditional risk factors. When it comes to women, menopause results in increasing triglycerides, increasing LDL, and decrease in the HDL. HDL is a good cholesterol. The higher it is, the usual cutoff for men is 40, but for women it is 50. They need to have a higher HDL to give them protection. So women are less likely to achieve lipid goals because of that reason, because of the menopausal changes. 80% of the women above 75 have hypertension, but only 29% have adequate blood pressure control. And diabetes confers a higher risk. We talked about it. Smoking confers. Obesity, again, in women also, a higher risk. And women have a higher prevalence, especially in our cultures, especially, in our parents and all that. Higher prevalence of inactivity contributes to all of that. And then emerging risk factors in women, having like a systemic lupus erythematosus, which is an autoimmune condition, increases the ischemic heart disease or the coronary disease risk by 3-fold. Somebody has gestational diabetes during pregnancy, they have a 4-fold increased risk of diabetes in their lifetime and a 59% higher risk of heart attack in their lifetime. The same thing with hypertension in pregnancy, gestational hypertension and preeclampsia. threefold higher risk of having a coronary or a heart disease. And early menopause confers 4.5 times higher risk of heart disease. And depression is more prevalent in women, and which doubles the risk of heart disease. So these are some variations between men and women. So that the heart attack that we talked about is the macrovascular heart attack so far. The big arteries have blockages, and you go in, do an angiogram, you find a blockage, you fix it. But sometimes people typically come with the symptoms. They have a heart attack. We know that there is some heart damage. You do an angiogram, the bigger tubes are all open. In that situation, we add most of the most common reason for that kind is the tiny vessels have blockages or spasm or something. We call it as a microvascular heart attack. You still treat them aggressively because that could lead to cardiac arrest and arrhythmias and things like that. There is something called a broken heart syndrome. You typically see in women more than men around the age of 60. Intense emotion, extreme stress contributes to some catecholamine changes in the body, which affects the heart muscle in such a way that there's no blockage, there is a heart attack, there is a damage of the heart muscle, the heart pump becomes weak, but you don't have blockages. So you just have to treat them with medications. A very common error that we used to do in the past is hormone replacement in women. Whenever they go through menopause, you would put them on a hormone replacement because they would have hot flashes. And what was shown later on was the hormonal replacement therapies contributing to higher risks of heart attacks in women. So American College of Cardiology, they recommend not to do that. Just like that. They have severe hot flashes only, they recommend that. Same thing with American College of Gynecology, North American Menopause Society, American Preventive Services Task Force. All of them mention hormone therapy is neither beneficial nor indicated for preventing or reducing cardiovascular disease. It's only pure symptomatic treatment right now. They have hot flashes, you treat them with hormone replacement. And one slide on the heart disease and pregnancy. There's not a whole lot of people, severe valve disease, and they become pregnant. They have congenital disease, something called pulmonary hypertension. There is something called peripartum cardiomyopathy. They develop weak heart during pregnancy. Not a whole lot, but need to be aware of. So Desi heart disease, Dr. Allah has talked about it at length, and I probably don't need to go a whole lot on statistic. 25% of the world population, maybe I can emphasize on that, but they account for 60% of the world's heart disease patients. So this represents a major public health crisis. And 25% under age of 40, 50% of heart attacks under age of 50. And they develop 10 years earlier than the general population on an average. So highest risk among all races, and our population crossing 5.5 million already, topic is catching more attention. Congress started funding more studies. There's another bill pending. One of the study that is akin to Framingham Heart Study. What Framingham Heart Study did is similar model, mediators of atherosclerosis in South Asians living in America, which they call it as Masala study, is one of the prominent studies that are being done. And she's the principal investigator based out of University of California at San Francisco, Alka Kanaya. So what is Masala study? South Asians living in the United States, those are being enrolled. It's a population-based sample, about 1,100 South Asian women and men aged between 40 to 84 years at 2 university clinical centers, University of UCSF and Northwestern. And the study is funded by National Heart, Lung, and Blood Institute. So from that study that we glean a lot of information. The greatest risk factor disparity in South Asians is their predilection for impaired glucose intolerance, resulting in twofold higher rates of type 2 diabetes compared to our Caucasian counterparts. Higher prevalence of type 2 diabetes in South Asians compared with other ethnicities, even after adjusting for age and adiposity, which is 23% compared to 18% in Blacks, 17% in Latinos, 13% in Chinese Americans, and 6% in Caucasians. So type 2 diabetes is a killer for us. Out of which 9.7% of the participants reported having diabetes during pregnancy. And women with gestational diabetes were 3.2 times more likely to develop diabetes eventually. So these observations highlight the need for early intervention in a younger high-risk population, and which is usually not done nowadays. Another thing that we heard earlier is that we see in Masala study also, people who have lower body mass index, the body weight and waist circumference compared with their peers in MESA, which is another ethnic study, including Latinos, South Asians had higher levels of visceral and hepatic fat, but less total lean abdominal muscle mass compared with all other racial and ethnic minority groups. We talked about cataclysmic integration of the East and West. That is a major problem. South Asian diet focuses on carbohydrates, rice, lentils, chapatis, naan, saturated fats like ghee and butter, but a conspicuous absence of focus on lean meats. And this merged with Western diet, like potatoes, pizzas, proves disastrous and has only added to the inherent predisposition to insulin resistance among us. The Masala study also found that the standard cutoff point for diabetes, a BMI of 25 or greater, would cause doctors to overlook up to. So when BMI of 25 or less, you basically say they're healthy otherwise. But in South Asians, that's not the case. The BMI cutoff should be lower for us. And we have a popular misconception that vegetarian diet is healthy. But look at Masala study, 40% of them are vegetarian. A common practice in India. If you go to Western India, in Gujarat, vegetarianism is pretty common. And it is thought as heart healthy. But vegetarians who eat traditional South Asian foods like fried snacks, sweetened beverages, high-fat dairy products were found to have worse cardiovascular health than those who eat what the researchers call a prudent diet, which has more fruits, vegetables, nuts, beans, and whole grains. And of course, for non-vegetarians, the lean meat, the fish and chicken. People who eat Western-style diet with the red and processed meat, alcohol, refined carbohydrates, and less fruit and vegetables were found to have more metabolic risk factors. So what are the 7 steps to a healthier heart? Eat a healthy diet, make vegetables and fruits, whole grains, and fish mealtime staples, limit sodium and saturated fat, and limit sugar, which is a key thing in us actually. Sugar is often overlooked. That predisposes us to our increased risk of diabetes. Get active, log 150 minutes of moderate intensity activity, brisk walking per week, or 75 minutes of vigorous activity, like intensity activity. Control your blood sugar, aim for a fasting glucose of less than 100. How do you know that? Unless you check your periodic blood tests once in a year, you wouldn't know that. So you have to get that done. Watch your cholesterol. And there are risk factor tools that we can calculate. And total cholesterol should be in general less than 200. But that is also personalized based on your risk factors. Maintain a healthy weight. Even though the slide says a 25 body mass index, we might have to strive to a little lower than that, maybe 22 or 23, because we are South Asians and we are higher risk. Blood pressure should be monitored and treated, and then live smoke-free. If you smoke and quit, your risks come back to your baseline as if you're a non-smoker within about 3 years. So it's never too late. Quit smoking. There is a request from some people for this webinar to talk about what's the COVID and why is it increasing heart attacks in people. We got a recent study from Nature Medicine that was published in Nature Medicine. People who had COVID and they were followed for 1 year, and they're compared to non-COVID patients in a 150,000 patient database coming out of Veteran Affairs hospitals in the United States, there is 55% more likely to experience a serious cardiovascular event in the first year after COVID. They were also 52% more likely to have a stroke, but when it comes to heart attack, it increases to 63%. COVID is known to cause increased thrombotic, like it means the propensity to form blood clots in the body. And we talked about plaque, and the heart attack happens because of blood clotting. There's another thing also called pulmonary embolism. Just like a heart attack for the heart, there's a lung attack, which we call as pulmonary embolism. So these conditions are increased after the COVID. So that means they seem to have a higher propensity to form blood clots in the body, whether it be brain, whether it be lungs, whether it be heart. And that is why we see the higher incidence. So that's what we know so far about it. And we will be knowing more, and later in the question and answer session, we can talk a little bit more on that. So with that, I thank you all for attending and paying attention. And I give it over to the next speaker.
Next speaker can start talking.
Dr. Suman. You're muted.
Suman.
Yeah. Can you hear me? Yes.
Yes, we can.
Yes. Hi, my name is Suman Manchuri. I'm an internist at Northern Virginia in Leesburg, close to Washington, D.C. I'm a practicing internist. I've been doing internal medicine for the last 15 years. I used to do hospital medicine prior to sort of my practice. So a little bit of the background. Since I started doing the hospital medicine, there was some stress going on. Then, I didn't like the hospital medicine. And then I moved into practicing, having a private practice. And when everybody is moving into hospital medicine, I moved out just because I didn't like the way the hospital medicine and the corporatization of medicine going on right now. And as you all know, in US, having your own practice, doing your own thing has its own cost. So for the last 3 years, I've been working my own practice, and I've been working in the hospital and other rehab centers. And 6 months ago, I had a major heart attack. And to give you a little bit background of how it happened, I was doing fine, and I really liked what I was doing job-wise, but I was having a lot of physical exhaustion, sleeplessness, stress with the patients calling all through I used to be available 24/7. I used to work all the time, just because of the nature of the practice. And one day early in the morning, around 5 o'clock, it all started to have a severe heartburn in the center of the chest. I do have a little bit of GERD. So GERD means gastric reflux. And I thought it was a gas pain. And then I started popping in some pills called pantoprazole, Tums. I took like a couple of pills, waited for an hour to go away. However, the pain was so severe. I couldn't rest, I couldn't sleep, I couldn't move, I couldn't get up and walk and all that. And my wife finally suggested, let's go to the ER. It's been almost an hour. So I went to the ER, and it's the same hospital where I work. I mean, I've admitted so many patients there. And the irony is that I was a patient at the same hospital. But I mean, lucky was in my favor. I went to the main hospital where it has all the services instead of a satellite ER, which would have been much more disaster because I would have lost time. So I went to the hospital, and I was still thinking it was not heart attack. It might be something else going on. Then as I went in, and they started hooking me up, whenever you have some pain around the chest or heartburn, they try to rule out for heart attack. That's kind of a procedure norm that they do. And when they did that, I saw my own EKG, and it was acute MI, which means a heart attack. And as soon as I saw my own EKG with it was showing that there might be something going on with my heart and the heart attack. They immediately called the code, and the team came in, and they took me immediately to get the angiogram. And as I think it's a time of an essence, and I was at the time where it was very severe in nature. And as soon as they were doing it, I went into cardiac arrest, and they had to give me shocks, a total of 6 shocks. And finally, I survived. There was so one of the vessels on the right side was 100% blocked. So I was having plaques sitting in that particular artery, and the plaque ruptured. When it ruptured, it blocked the whole artery. So there was no blood supply on the right side of the heart. And that was contributing to the symptoms that I had. So he did the interventional cardiologist who went in, he sucked out the clot, he took the clot out, and he put a stent in. And during that procedure, that the cardiac arrest, the heart went into the rhythm, which can cause cardiac arrest. And then they had to shock me and revive, and I was brought back. I was lucky enough to be survived because the study suggests that the risk of mortality is as high as 50%. So every other person cannot make it. I was lucky enough in that manner that I survived. And then I was transferred to ICU. Usually we monitor for a day to see how the heart is functioning and how weak the heart became. I lost some of the heart function on the follow-up day. And I was feeling extremely fatigued, which can happen after the shocks. So after day 2, I slowly recovered, and I was discharged home. And of all this, I think there were a couple of factors going on. Now that I'm a heart attack survivor, I love preventive medicine. That's what I do most. The reason I left the hospital medicine was to do more of preventive care to my patients, and be available to my patients and help them as much as possible. But I was not very aggressive, looking at South Asians or one particular ethnicity versus the other. I was treating everybody the same. However, this has changed my perspective. and I'm starting to write some blogs, medical blogs, and to make awareness. And ATA has really given me the platform. Dr. Sujit Garu has asked me to come and talk about my experience that happened 6 months ago. And I'm very happy and to be here, to be discussing with you, to have a general audience that this problem is much more deeper than it seems. And I run a lot. I do 5 miles every time I run. So I exercise, I eat okay. I mean, I eat more like intermittent fasting. I eat only like 2 times a day. So I control my diet. I do a good nutrition. And I've been actually telling other people. So I try to live by example. But however, it happened to me. So then I started looking into more studies now, and I've been writing, and there is some lag between the studies and what we are practicing. I think Dr. Ala and Dr. Punam really shown some of the studies, what's going on right now. But I think what I'm doing right now in my practice is that I consider every South Asian a disease risk. I don't see the high, moderate, or low. I start with the high risk. I peel them down. I do all the testing to make sure they don't have those diseases. Because the studies have shown that you don't have to have diabetes. You don't even have to have even the pre-diabetes. You can be just starting of hyperinsulinemia, which, the starting of metabolic disease, and that can also increase the chance of heart disease and putting a plaque. So there is a lot of metabolic changes happening decades before. And I'm looking in more into studies, and it's just alarming the amount of heart disease that's going on in this part of community. But I'm trying to do whatever I can now that I'm a survivor. I mean, I would have been, on the other side, and luck was on my side, and I'm going to try to do everything I can to help to reach the general audience, to make people aware of this serious problem. And again, I thank you, Arta, for allowing me to speak and tell my experience. And if you have any questions, concerns, or anything, you can call me, or I have my blog. I can post it, and anybody wants to follow, they can follow. Thank you again.
Thank you very much. So next speaker, Sujit Garu. You're on mute.
Yeah, we can start taking the questions from the audience, and and start discussing point by point kind of a thing. Dr. Ranginani is also there, so he will also take the questions.
All right. So we have questions. I'm going to read it out loud. So there's a question from Bhaskar Vanepalli. He's asking, before statins were introduced, death from heart disease were highest. Despite of benefits or billions of dollar statins, still heart disease deaths are high. Please explain reasons.
It's a very good question, Andy. The way I look at it is the heart disease is so complicated. There are so many things we understand and so many things we don't understand. The way I look at it is, there's a good genetic study done correlating with what genetics what will predispose you to coronary artery disease. And they came up with anywhere from about 100 genes, which are predictors of how they impact your coronary artery disease. So statin and cholesterol is a very small factor in the whole scheme of the heart disease. The way I look at it is, your heart disease, there is some known, and then some known unknown, and there's a lot of unknown. So at this point, we can, there's no point in worrying about unknown, because we don't know what we don't know. And there's no point in worrying about what we clearly know that we don't know how to predict it. But we know what matters. And what matters is the statins. And from a practice perspective, statins made a big difference if used, and at least in this country. And I'm a little older than these other two guys. So when I started practice, we used to get a lot of heart attacks which are emergent. And as statins evolved and community, at least in US, more people started using statins, we get less, we call them ST or emergent MI indaka. Suman garu cheppinattu atlante heart attacks takvayi, we're getting more complex delayed intervention. So unfortunately, to answer the question, we don't have any good way to reverse the disease process. We only have interventions to slow the disease process. And statins is one big player where it has significantly slowed the heart disease incidence from younger age to older age.
Yeah, I'll also add to this. I don't think the mortality of heart attacks has increased. If that's the question he was trying. The mortality of cardiovascular disease actually has decreased steadily since the 1980s because of a lot of things, except for the last 3 years. Now, I don't know if that's all due to statins, because there is statins, there's better blood pressure control, there is decrease in smoking rates, there is better care, stents are getting better, STEMI care has gotten better. So a number of factors. Actually, the US data is very consistent that the cardiovascular mortality for every cardiovascular disease, MI, heart failure, has actually decreased. The problem is the prevalence has increased. That's because now the same heart attack patient who would have died 10 years ago lives. So he's going to be a survivor of heart attack, and his disease prevalence. So there are more people living with heart disease because I think the technology in the US is getting better. The care has gotten better, and statins are one part of it. In India, that's not the case because the systems of care have not gotten better. The habits have not gotten better. Now, there is some 2 or 3 years of data. There is the trend creeping back up, even in the US. And I think that's predominantly all the gains of statin and hypertension, smoking cessation is now being washed away by the epidemic of diabetes and obesity and overweight. So I think, like Dr. Anil has said, the mortality has actually gotten down, but the prevalence and the burden of disease has increased because now these people live longer.
Yeah, so I'm familiar actually with one of a study, a population-based study. That it's a very interesting question. Actually, we see that in the clinical practice a whole lot. And if you look at it, the life expectancy has increased in the United States tremendously compared to, the reason why Framingham Heart Study was instituted in the beginning in the 40s was because people were dropping off like flies at that time. Because of the fast food that came up, people were having heart attacks and dying like flies. That's why the study was started. If you look at it at that time, the life expectancy was at least 20 years less than what it is now. And then they looked at why is the life expectancy increased? And you go by all the factors, treating cholesterol with statins amounted to 30% reason for that. So hypertension a little bit, diabetes a little bit, but statin played a huge role in it. So they do help, but it's not like Dr. Anil mentioned, there are certain things that we don't know yet, so we cannot treat it.
All right, thank you. Next question basically looks like we already answered this, but I will read it out. These questions are from Bhaskar, Ramki Palle and Srini Koma. How do we recognize the symptoms early enough? And my cardiologist buddy suggested coronary calcium scan to find how serious blockage is in the body.
So there's a lot of variables, Sandy, how, when you will get heart attack. So the coronary calcium scan is a good thing. I would recommend that strongly for all the, particularly Manaku, they have so high risk of coronary artery disease. And it gives you a number But it does not tell you when you're going to have a heart attack, but it's going to tell you from next 5 years lo meeku enta risk undi to get a heart attack. So once you know that risk, you may want to get way more aggressive with the interventions. But I love the comment Suman made, that he said every South Asian is high risk. So irrespective of calcium score or what, we all need to treat ourselves as high risk, and we have to give aggressive intervention. As far as the symptoms, again, it comes back to the same thing. I like statistics a lot. So think about it. If your chance of getting a heart attack is very high, when you get a chest pain, first acid, ఇవన్నీ అనుకునే ముందు first heart attack అనుకుని తర్వాత acid వీటన్నిటికి పోవాలి. ఎందుకంటే you don't die from acid reflux, you don't die from the other problems, but you die from a heart attack. And you're a South Asian, you have a high risk of getting heart attack. Think of that first, think of the other things later.
And
All
also
right.
to give, I have a suggestion. So also the thing is, the studies have shown that you just need 30% of blockage. You know, the people who have 30% of blockage did worse to have heart attacks than people who have 80-90% blockage. So knowing it early, doing some studies that suggest will actually help them, help the patients to better manage and better take care of them. So, yeah.
Yep, I'm the better example. Actually, the incident happened yesterday. I just got a little heartburn and got some sweat. Then immediately I went to ER and I made my EKG. And last night actually I was in the ER. So, but everything was fine. Then they relieved me and came up. But yeah. So
That's good.
any system, anything we feel like, first we need to go to ER and make the things done properly.
Yes.
So, yeah. So last night I was in the ER because one of my friends, Srini Gangasani, I called him. He said, okay, within next half an hour, you should go to the ER and call me back. So that's what he suggested. He's also a cardiologist. All right. The next question. All right. Soma Narasimha Reddy is appreciating ATA. And after, definitely, I will give all this credit to our health chair, Sujit Garu, and of course, ATA team too. By bringing up the good sessions to the community. And the next one, I have a question. She's asking, is the eggs good for diet apart from fish and chicken?
It's a good question, and there's a lot of confusion about it. They pushed a lot, saying that yellow of the egg is a problem and diet is a problem, and how much of your cholesterol comes from diet and how much of your cholesterol comes from your own production. So it's a combination of things. Most of the, surprisingly, mana Indians ki anta high cholesterol undavu. The breakdown of the cholesterol is usually the problem. The HDL, which is considered a good cholesterol, it always runs low in our people, and the bad cholesterol is marginally high. Very few people you see a lot of it. There's something called lipoprotein A, Alagar chapter, and that's also elevated. And unfortunately, how to intervene in those things, there's a lot of drugs and research going on, but nothing came out for lipoprotein A and breakdown of small particles. But even if you go with the dietary recommendation by the US, they pushed a lot about not eating yellow of the eggs, and they backed off of it because bulk of the cholesterol is being produced by the liver. And a lot of your genetic factors matter more and then some of the carbohydrates rich diets can actually get converted into cholesterol in the body. So it's very complicated. As of now, I think eggs are in the neutral stand, where they are neither considered very good or bad, and fish and the other parts are considered on the good side.
So just for a ballpark figure, Anil, can we tell the audience that, maybe one or two, if somebody really likes eggs, eating one or two in a day is probably okay? Again, it cannot be 100% true, but
I think in moderate eating of eggs is absolutely acceptable. I think that should be the way, at least as of now, till we know more information. So I mean, I basically categorize everything into like a something that we know for sure, we know we don't know, and we don't know what we don't know. So this will fall into where we know we don't know for sure what to do.
But I'm sure, I think you guys might have heard in India, and Sunday ya Monday, Rose ka Monday. I don't know why.
Yeah, I guess one egg a day, at least, probably she's going to be healthy.
Yeah, honestly,
I think it's all about balance.
Go ahead.
Yeah.
Protein malnutrition used to be a problem in India before the poultries came in and the egg production exponentially increased in India. So I don't know if you remember, Sujit, but when I was a medical student, you're a little behind me. We saw a lot of protein malnutrition in the hospital, but I don't think you see it anymore in India. And a lot to do with eggs and their contribution to the diet. So it has done a lot to the overall human being's nutrition. So I still feel like you're right. 1 or 2 eggs don't make a big deal. I think you should eat some if you're not against it or you don't like it. I think eating eggs is okay.
I think the moderation, like you're saying, the moderation is good.
Moderation.
I think the issue is with the carbs. I mean, the protein and fat is all right, but I think the more, and we have to concentrate more on the carbs. The amount of carbs we consume is exponential, so that needs to come down. The eggs wise, I think 1 to 2 eggs should be fine. I think in overall picture.
And the problem with not eating any protein stuff is your satiety is so bad that all you're doing then is eating carbs. So I think it's all about balance. You need to have good protein, which egg is a good protein. Yes, egg does have some fat, but it is moderation. And I think you should have a fair amount of healthy fat. That's also important. We don't eat very many nuts, though, we should start doing that. And, fish, not the catfish, but the more healthy sea fish and cards and stuff. So salmons, I think it's important to have things in balance. I think when we try to push one over the other, that's when we get into trouble. But I think fat and protein should not be looked at as enemies, because what you're replacing with is carb, and that's probably the number one enemy in our diet.
Yeah, it's a great point. I think we need to stress a point that we need to have everybody increase their consumption of fruits and nuts, which give you good nutrient value, vitamins, and all that stuff.
In fact, if you look at the data from InterHeart, one of the studies that I presented, the risk of heart disease in Indians, they looked at what are the factors. It's not what we were doing as much as what we were not doing. Yes, we were eating some unhealthy foods, but majority of the risk was driven by the fact that we are not eating any fruits, veggies, and nuts. So we were doing worst on that outcome. They measured healthy behaviors, and the Indians did worst on not eating fresh fruits, veggies, and nuts. So I think one of the editorial on that said, it's not what you do, but it's what you don't that counts more.
Right. So the next question is from Selva Sabapati. He's asking a question and request too. So what is the difference between hospital medicine and preventive medicine? And is also asking any link to this survivors doctor's blog.
Sure. I mean, I'm going to share it. Anybody can, take a look at it. So hospital medicine is when the physician does only hospital medicine work. He doesn't do any outpatient or any other practice. So, but when you do outpatient, like it's internal medicine, and so basically the internal medicine is more of preventive medicine. You have to engage with patients to try to prevent things. And the reason I came out was the hospital was like aftercare. Like everybody gets sick, they come to hospital, you take care of them, and then you send them home or what have you. But on the other side, the internal medicine side, the office side is more of you spend time to take care of patients, whereby you are trying to prevent them from going to the hospital or getting worse or getting heart disease, diabetes, what have you down the road. So catching the things earlier and prevent them from getting worse. So that's what the preventive medicine, and that's what I'm trying to do. So.
So
All right,
in
and
crude man's example, preventive medicine is like taking a safe driving class, and hospital medicine is like calling Geico once you had the car crash. You know?
Yeah,
That's a good one.
something like that. Yep.
yeah, that's a good one. All right, and the next one, Srinikoma, once again, he is also saying, thanks for sharing your story, sir. Please share link to blog. Also, please tell us what lifestyle changes are adapted since the ordeal.
Yeah. So there are 5 things I'm doing right now. Good restful sleep. That is absolutely necessary. I think that's one thing I didn't have for the last 3 years. I was getting calls all through the night and day. I mean, I was getting too many calls because I was doing hospital patients. I was admitting patients in the hospital, in rehab, nursing homes. So I was just going everywhere to establish practice and all that. So the last 6 months, I've been sleeping very well, at least 7 hours of sleep. The second thing is taking medications. I mean, I'm on a lot of medications now, but I put alarm to my every day to my phone and make sure I take my because the compliance is very, very important in heart disease. That's a lot of people take it lightly. I think that's one of the things everybody should be. If you are prescribed some medication, you got to take it. So that I do diligently. Then stress in the sense that I cut down my hours. I work only 3 to 4 days since that happened, and I'm trying to do certain things. And I stopped going to hospital anymore. I'm not doing hospital medicine. I'm not doing rehabs. So I'm just concentrating on outpatient medicine. And obviously diet, I cut down significantly. I stopped actually. I'm more trying to be on vegetarian. I call vegetarian, I don't call vegetarian, I call rotarian, okay, or livetarian. So you have to eat live veggies, the ones which has active life in it. So you steam or you do more salads and a little bit of protein on top of it. I'm trying to cut down on processed food, fast foods. Obviously, those that all have cut down. Yeah, like I said, the stress, sleep, stress, then activity, physical activity. I do walk. I love to run. I'm still in a period of recovering, so I'm not doing that much running, but I'm planning to do a half marathon end of this year. So I'm going to start my training for that. Yeah, those are the things. I think I emphasize mostly on the balance of everything, So I tell my patients about 8-8-8 rule, which is 8 hours of work and disconnect after 8 hours. 8 hours of personal time, which includes activity, family time, and all that, and 8 hours, 7 to 8 hours of sleep. If you're able to do that, I think that will help for your heart. That will help for your stress, good night's sleep. So that way you are doing much better in the long run, and you're taking care of yourselves. And I think that way, by doing that, the diseases and all that, you are controlling them. So I think if you are able to inculcate these habits, then I think you will definitely do good long term. It's not a short term thing; it's a long term thing. People think if you do something drastically and then because you go to other side, once you start doing better, you feel better. So I think you have to strategize for long term. That's why the preventive care is very important. Having a good doctor who is able to listen to you and able to understand, do preventive medicine, do more of counseling on these aspects would really, really help.
All right, maybe we need
Anil, one question. Can you hear me?
Yeah. Yes, Kiran.
Yeah. Go ahead. Yeah. So one question that I'm seeing is from our audience is what's the difference between the heartburn, like the gastric issue, and the heart attack? Will as an average person will know the difference?
It's a good question and very hard. A lot of the doctors have the trouble too. If you think about it, maybe anatomically, to give you an idea, the stomach and esophagus just lies just behind the heart. So to understand the pain system, మీకు ఇప్పుడు పెయిన్ ఆన్ ద స్కిన్ ఎక్కడ కట్ అయితే అక్కడ నర్వ్ కి అక్కడ రెస్పాన్స్ వస్తుంది ఇమీడియట్ గా. Whereas once you get past the skin and inside, the pain is not from any touch or cutting. It's usually from stretching or from not getting enough blood or oxygen. And they go to the brain and it communicates to a focus. A heart pain, which can come from heart, can be in the reflex laga ravachu, right upper quadrant pain ravachu. Pain can go down the left arm, because these are all the nerves which correlate with the brain center where it perceives the pain. So reflux and heart attack pains can be extremely close. So I would say go with data, basically. The bottom line is that you look at your risk factors, and being a South Asian, you're a very high risk for heart problem. Very simple as that. And you don't die from heart reflux disease, but you do die from heart problems. So you want to make sure as soon as you get it, think of heart problem first and reflux second.
Very underutilized, I want to add a point here, is a very underutilized service is urgent care centers. Say, for example, Anil just mentioned, Anil just mentioned that he went to the ER. Say you are not close to the ER, there are a lot of urgent care centers. You can quickly go there and get an EKG. So you don't need to wait for your own doctor to come in if you are in a weekend, you can just drop in, get an EKG. Very underutilized. I get a lot of calls from family and friends when they are visiting US. I have this kind of symptoms, what do you do? To be honest, I don't know actually, because hard to tell. 55-year-old female, one of my relative came from India, having a little bit of touchy pain lower side of the chest. So now what do I tell her? I did tell her that if at any point there is a little bit more change in your symptoms, go to the urgent care center. Don't hesitate to get that EKG, because that definitely gives a whole lot of information. That's very underutilized is what I think.
Sujit, I had a personal experience. One of our Indian, basically, ఒకసారి వచ్చి కలుస్తానండి, కొంచెం ఏదో గ్యాస్ లాగా ఉంది అని, he just I said come right away. He showed up. I drove him to the hospital with me because he was having a heart attack. Took him to the cath lab directly, opened up the artery, and then discharged him. But the point is, you got to think of it. I mean, what are you going to lose by thinking of it as a heart problem than reflux? Sure, under some medical care and experience cost a little bit, and you could go to an urgent care to lower the cost and not go to the emergency room. That's a good decision. But I think you got to think of the heart problem first.
Yeah, I think it's easier said than done. I think most doctors will still themselves have, even like you just saw the survivor story of how for an hour, we think like that. And I mean, we are all humans. Before we are physicians, we are always thinking of the good,
Wishful thinking.
I'm pretty sure that when I tell my patients, this is what I tell: you need to be right every single time to be alive at home, and you need to be wrong only once to die at home and not ever make it to see me again. So, but when it comes to you, you're always thinking we are all guilty of that. There is a denial, So like somebody said, I think you should think of the worst before you think of the best, and, put everything aside and at least get an EKG. And hopefully Apple will come up with a way they can reliably give you an ST segment analysis. Right now, they give rhythm analysis. Hopefully by the time, in 10 years, hopefully we'll have EKG smart tools where people are, you're kind of trying to draw a line between being careful, cautious, diligent, going to the ER, and being considered the paranoid guy that, every 2 weeks this guy is here. So.
Yeah, but Venkata, your data is so alarming. It's mind-boggling. The amount of incidence of heart disease in South Asians is so high. So the only way to be proactive is being more aware of it. So the chance of you being right when the incidence is so high, if you think of that problem, you're going to be right more often than wrong. So.
All right, I think we'll take the next question now. Mahendra is asking like, my calcium score is 98. Can we reduce plaque build up with the change in diet and regular exercise without using aspirin and cholesterol medicine?
First of all, the calcium score, you cannot reduce it. We don't have a way to reverse the process of the heart disease. And the intervention of cholesterol and all that stuff is only to slow the chances of you having a heart attack. In that Suman Garanatu, 50% of the heart attacks are from people who have blockages less than 50%. So if you look at the study that the Vietnam, a lot of young people died during the Vietnam War. So they did a lot of autopsies on them. These are age group of 19 to 25 years. And all these people already had the beginning of the atherosclerotic disease. So it starts very early and it keeps increasing with age. And how fast it increases depends on your risk factors, genetics. And being an Asian, our risk is high, that we'll go faster there. So you have to do all the available interventions, which include, like I said, what we know are diet, exercise, and lowering your cholesterol, and reducing stress, which is very well known fact, but a very complicated thing to do because it gets into a big complex mental health stuff where yoga, meditation, and all that stuff, and not being too, get it too much into it, is that you need to be less reactive to what happens around you, which automatically reduces your stress because you don't have control on how people react, but you have control on how you react to circumstances. So yeah, you can do all the other stuff, but to be honest, the biggest data of reducing chance of heart attack is with statins.
With or without medicine. Okay. Next one is like how good to take baby aspirin and at what age?
I will take that question. So I think that is the other controversy in medicine.
Right.
You know? I don't think in general that we would recommend for aspirin. So somebody just told me about a calcium score of 98. I would not recommend aspirin in those people. I would definitely do recommend statin. I think that's what I do. But the data, if you're 55 and older in the general population, people say that there is a risk of bleeding with aspirin. At the same time, it does decrease your risk of stroke or heart attack, depending on being man or woman. So under 55, I had a tough time saying aspirin is proven to be protective. So I don't recommend that.
Yeah, continue from there. Yeah. Okay. So.
Go ahead.
Yeah.
No, I don't know what the other physicians on this panel think about it, because you know, in medical school we were taught aspirin is the wonder drug, and then it goes back and forth, it swings back and forth. So I think if somebody's risk of bleeding is very low and they're 55 to 65 or above and want to take an aspirin, I don't stop them. But in the very young people, I think it is statin that will pay them more benefit than aspirin.
I think we have to separate out the role of aspirin in primary prevention and secondary prevention. What I mean by is that secondary prevention, already you have heart disease and you had a heart attack. And the primary prevention is you didn't have a heart attack and you're trying to prevent. There is no controversy in secondary prevention. If you already have a heart disease or a heart attack, you need aspirin. It will prevent you from getting a second heart attack. As far as the primary prevention, you don't want to get a heart attack and you want to take an aspirin. Like you said, the younger you are, the less benefit you're going to get. And I don't know, correct me if I'm wrong, you guys have been doing a lot of research in this, that there's no data to show if there's just a calcium score high, but no other metrics and no previous event if aspirin has any role in it.
Yeah, so basically people have studied the primary prevention role of aspirin in a lot of high-risk groups, which are no disease to begin with, for example, diabetes, but it's not proven. So even in diabetics, there is no convincing evidence that aspirin for primary prevention works across a broad group of people. There's not been any study picking people with a high calcium score plus diabetes or a high calcium score, no diabetes, assess the relative benefits in primary prevention of asthma. I'm not aware of any such data.
And yeah, and sorry to interrupt. We have more than 1,000 users today, and we have a lot of questions to answer. So can we cut it short and just continue with the questions? Sorry.
Sure, I will give one-liner on that topic. What I do is I calculate a risk score, like I mentioned in my talk. If their risk is less than 7.5% in the next 10 years, they don't have a prior heart disease, I don't give aspirin. If they are moderate or high risk, and if they are age 65 or above, I definitely put them on aspirin. That's what I do.
All right. And can you continue with the questions,
Yeah.
please?
So, yeah, the next question from Udaya is what frequency of heart attack at what age of our community to identify? Oh, can you hear me?
Yeah, we can hear you.
Yeah, we can hear you.
Yeah, okay, got it. Yeah, so the question is, what is the frequency of heart attack by age in our community? Like, to identify the criticality of numbers indicating. Like, I think the primary question is on the age. What is the age that you normally?
You want to take this question, Venkat? I think you had the data.
Yeah, so, if you're asking what is the population incidence, mostly there is no population incidence in the South Asians here because, the denominator is always variable. And even when you look at Masala, it's all primary prevention with the 1,100 people. Now, the data on India is different. So if you look at India, the age adjusted rates, I can't remember off the top of my head, but it is still quite high for young compared to our US population. So I would have to say it's about 20 per 100,000, something like that, but I can't tell you off the top of my head. That 20, that's a global, across all ages, 20 per 100,000. As you go older, it is higher. But when you look at by decade, the rates at 40 and 50 are still much more higher in India than US.
Got it. Got it.
I think
we can move on to the.
Yeah, I think Kiran, she corrected her question. Maybe she's asking like what time, whether I need to call 911 or whether I need to take CPR. What early means, maybe that is her question. See if you see she corrected question.
Yeah, if you pass out and you collapsed, that is when you do CPR. If you are alert, you're having symptoms, you call 911.
Got it.
You also call 911.
Yes,
CPR.
Both, yeah. For both.
Yeah, Neil, we can't hear you.
I think if in doubt, just call 911. That's it.
Can you guys hear me? Can I ask you next question?
Yes, Kiran, you're audible. Can you continue your question?
Okay, got it. So in patients with diabetes, which is very high, generally high in Indians, so would they experience a huge pain when experiencing a heart attack, or would it be more unnoticeable?
So yeah, it's a good question. Diabetics don't get as much pain as other people get. And so if you're a diabetic in South Asian, I prefer that you already go see a doctor and get on all the treatment, then wait for symptoms to appear. And you should have very low threshold to call 911. If you're a diabetic and you get any symptom, you should call 911, anything related or suspicious of any way close to the chest.
Got it. So the next question, yeah.
Dr. Ranginani, I have a quick question for you.
Go ahead.
Go ahead.
Yeah, the thing is, most of us, they tend to read WebMD, because it's hard to, most of the professionals here are like IT and they tend to read a lot of internet stuff. So when they run into some issues and it's hard to get the appointments. So is there a proper resource which you can refer to? Because given the appointments, the schedules and all these, it's hard to get these appointments. Is there a resource which you could refer to that could help us from from a physician's perspective, from a cardiologist's perspective?
Yeah, there's a lot of telemedicine starting that you can get appointments sooner. That's one. And then the other option is go to legitimate websites like Mayo Clinic and Cleveland Clinic have websites explaining all this stuff. WebMD per se also has good literature on there. But unfortunately, when you go on Google, these are not the first three that come up. Everybody has their own. Please do not go to WhatsApp and what your friends send in WhatsApp forwards, because it's just totally out of control. All kinds of data come in there. So go to some legitimate website like Cleveland Clinic or Mayo. But if you guys have any other suggestions, AHA has a good website too.
Yeah, I mean, think if you're having any acute symptoms that's new and they're it's in your chest, I don't know if I would look anything up. I mean, the one thing you need is an EKG. So I don't think even the smartest doctor, if you talk to him, can get it right. I don't think I'll get it right in myself. So if you're having suggestive symptoms, you're in the right age group, 40s, I think you should err on the side of getting an EKG. That's as close to. Now, if you're having chronic symptoms, something is happening over 2 to 3 months and you're worried, you want to look up, yes, all the things you said probably are reasonable. But if something was well yesterday and today you're not feeling right and it is remotely concerning for heart, I think you need to be seen right away.
And also, Dr. Alla, I mean, your presentation, you were saying something about biases and all that. I think which is very true. We tend to ignore health as South Asians. I think it's a religious bias or faith-based or I think it's just the way we brought up. I think it's that we don't reach the medical professionals, for preventive care or for proper advice. I mean, you go to them. I see a lot of patients. They come for one visit and they never follow through. And either they go for homeopathy or Ayurvedic or any kind of alternative care. I know we have too many things across, but allopathy kind of gets lost in between, and they come in only when it's when they're in chest pain or they don't come for like a lot of preventive care. I think that needs to be emphasized more, because by the time you see a cardiologist, it's too late. I mean, you are after care. I mean, it's the internal medicine and family care. They are the first, I think, gatekeepers. Try to do as much as prevention, and then obviously the cardiologist also helps in between. But I think it's the patient need to understand that they have to go and seek and make sure that their health is priority. It is very important. I mean, with me having a heart attack, I mean, there's a lot of people roaming around with with having some kind of plaque sitting there. And the risk needs to be adjusted and make sure their lifestyle is taken care of.
Sujit, Sujit, I think you have a lot of experience. You're in the tech world. Did you have any experience with CardioMobile? How good is it as an EKG for ST? Even Venkata, you can take the question too. You guys have any experience with it? Because it gives like a 3-lead EKG.
Yeah, I have a pretty good set of people that I follow with Apple Watch and CardioMobile. They're very good for rhythm. The ST segments are not very reliable. They're all transposed. So I have not yet seen any patient come to me with an ST that looks real or, so I think they are basically not reading the electrical injury. I think they're somehow doing back transposition based on your pulse. So they're getting your pulse volume or color and then transposing it to a heartbeat. I don't think they're getting the electrical signal. So I wouldn't believe any ST segments on those, but I could be wrong. I have not seen it. I have about a panel of 25 patients. After I convince them about this, I get in trouble because they're sending me images on chart every day. So it's overwhelming.
Yeah, I agree with Mahesh there. I don't think the Apple Watch that gives a very good rhythm analysis is still anywhere close to giving a good ST changes that will indicate if this is a heart attack kind of presentation. We can go to the next question.
We'll take one more question. Given the time, we are 3 minutes away from closing our session. So we'll take so the one last question is like, if Indians are at a high risk of heart attack due to genetics, why are we seeing more deaths now only? Is it only the food that caused that is related, or anything else that's changed? And again, I think one more time, if we can do the preventive ones at the end of it, that would be great.
Yeah, I think
So the
it's a
question is,
combination.
yeah.
I think
You
it's a
take it back.
combination. You are putting the person that's genetically primed in the midst of an environment that is promoting. So that, I think, it's coming off two things together. You know, we were, so back in the day, I don't know, most of you probably eat arisilu. So I grew up in the late 80s, and when we made arisilu, then we had to pound the rice. So between my grandma, my kids, my sisters, we had to pound that, and then we made that arisilu at home. It took a couple of days for Shankranti to make that, but now I can order arisilu all through the day, and I can keep getting packs. So what we have done is we are genetically primed, but our environment was very forgiving. We were working a lot more. We were in an agrarian community, so that protected us. Our genes didn't change. Now you put me in a situation, it's like drinking and sleeping versus drinking and driving in the car. So we were always drinking, but now we are drinking and getting in the car. So that changes.
You know, if I may quote a hypothesis that I read about, there's something called Nelson's hypothesis. I don't know whether you heard about it. You know, we are all primed right from when we were in the womb of our mother. You know, the kind of food that your mother is exposed to has a bearing on how we do eventually. Like, you know, so that's your baseline, whatever kind of food you eat. Now you're exposed to like 1600 calories of diet every day. And then you're born from your mother's womb. And then you start consuming 2400 to 3000 calories in a day. You are a ticking time bomb, is what it means basically. So when you are growing up, when you are very young, and your diet is significantly changed compared to like when you're in the 40s, 50s, and 60s, because of the, you know, increased prosperity and availability of things that are around us, that's basically increasing your risk.
Yeah, honestly, I think we have a lot of hypotheses and theories. It goes back to what I said in the beginning. There is so much unknown, and we might come up with some explanations, and that will change with time as data comes out. But I would say some of these are all in the hypothesis realm. So you have to take it with a pinch of salt that they have to be proven, whatever we suggest. What is proved is what we address from a prevention perspective.
Great. With that, I think we'll conclude the session, and I want to
Can I ask one question, Kiran? Kiran, can I just ask one quick question?
Yeah, go ahead.
To Dr. Allah. I heard he mentioned there is a difference in between the fish also. If you can a little bit, you know, open it up a little bit. That way, I know a lot of people are looking forward to some guidance on the food, and I think that's a very important question to answer.
So what we need to have is fish rich in PUFAs, or polyunsaturated fatty acid. And so the fish are themselves graded into three different. So there are fish rich in cholesterol, fish rich in monounsaturated, but traditionally the cods and salmons are considered the healthy fish. They're sea grown and they're generally rich in the PUFA. So we're all targeting the PUFA content of the fish. Now the catfish, the prawns, they're all in the middle, and there are some terrible fish, I don't remember the name. So we can't treat all fish as equal. And what you're looking for is the PUFA content of the fish, or polyunsaturated fatty acids.
Thank you.
Great. I know we couldn't answer all the questions today, but we will try to answer. We'll send these questions to the subject matter experts and get those answers answered on the YouTube. And with that being said, I want to thank Dr. Anil Ranganani Garu and Dr. Sujit and Dr. Venkatala Garu for your valuable time. I know how important is it to spend with our audience. And also, Dr. Suman, it takes a lot of courage to come out and explain everything what you experience. It is a very noble thing that what you're doing. And want to thank ABR Network for live streaming this one, and of course our own Banu and Bhunesh Garu. And one thing I would like to stress is that we are going to have a lot of these medical related, health related sessions in our upcoming conference in DC, July 1, 2, 3, 2022. It's a mega conference with almost 10,000 people that will be attending, with a lot of health experts. And apart from that, we also have Sadhguru, who is also going to visit to give his message, and a musical concert from Ilayaraja, and many more celebrities that are coming. So it is a must watch one. So we'll try to, and if you have any suggestions about the topics, we will post on our YouTube channel. So with that being said, we will conclude this session. Thank you everyone for watching this session, and I'll see you on the next webinar. Tomorrow we do have another webinar on the CPR by the eminent doctors. So please do watch that. Thank you all. Bye.
Thank you.
Thank you.
Thank you.
Thank you.